Coming to the next case, a 50-year-old man was admitted to the hospital with a complaint of persistent vomiting. On examination, he was dehydrated and his respiration was shallow. He gave a past history of dyspepsia. The result of lab investigations are as follows: pH 7.7, bicarbonate 45 milliequivalents per liter, PCO2 60 mmHg. So, what is the probable diagnosis? Let's see what it is. So, we have a case with persistent vomiting. pH is increased to 7.7. Towards the diagnosis of metabolic alkalosis. What this metabolic alkalosis is? Metabolic alkalosis is a condition in which the pH of tissue is elevated beyond the normal range. That is, the normal range is 7.35 to 7.45. Here in this case, the pH is increased to 7.7. Metabolic alkalosis is increase in pH due to increase in bicarbonate concentration, either due to excess loss of acid or abnormal retention of bicarbonate. The condition typically cannot last long if the kidneys are functioning normally. The bicarbonate to carbonic acid ratio is more than 20. So, metabolic alkalosis may be generated by one of the following mechanisms, that is, loss of hydrogen ions, shift of hydrogen ions into the intracellular space, alkali administration, contraction, alkalosis. So here in this case, we can observe pH is increased due to increased bicarbonate. Again, bicarbonate levels are increased, which is due to loss of acids due to persistent vomiting. So here in this case, it is loss of hydrogen ions due to persistent vomiting. PCO2, it is increased due to compensatory hypoventilation. Now, what are the various causes which can lead to metabolic acidosis? As in this case, it is mainly due to vomiting. The causes can be put under two categories depending upon the urine chloride levels. One is chloride responsive metabolic alkalosis. The other one is chloride resistant metabolic alkalosis. So, chloride responsive metabolic alkalosis is mainly due to loss of hydrogen ions. So, the principal causes of chloride responsive alkalosis are the loss of gastric secretions, ingestion of large dose of non-absorbable antacids, and use of thiazide or the loop diuretics. When it comes to the other one, that is chloride resistant metabolic alkalosis, is mainly due to retention of bicarbonate. That is where it is due to secondary or compensatory metabolic alkalosis in case of hypokalemia, in case of hyperaldosteronism or the Conn syndrome, therapeutic administration of bicarbonate, which can end up with retention of bicarbonate leading to metabolic alkalosis. Now, how do you get to know that it is a case of metabolic alkalosis? With again, it is the clinical features and the investigations. So, how does a patient with metabolic alkalosis present? The clinical features of moderate to severe metabolic alkalosis include abnormal sensations, neuromuscular irritability, tetany, abnormal heart rhythms again, coma, seizures, and delirium. So, these can be the clinical presentation of a case of metabolic alkalosis. So, what are the compensatory mechanisms? That is, how does body try to combat with this disturbances? The primary compensation is by the lungs. That is, hypoventilation occurs so that the loss of carbon dioxide is slow. Normally, arterial PCO2 increases by 0.6 to 0.75 millimeters of mercury for every 1 milliequivalent per liter increase in plasma bicarbonate concentration. The secondary compensation is increased excretion of bicarbonate by the kidneys, diminished formation and excretion of ammonia. These are the compensatory mechanisms which are seen in a case of metabolic alkalosis. Coming to the investigations to diagnose the case of metabolic alkalosis, mainly the arterial blood gas analysis and the serum electrolytes along with blood sugar, creat, and urine for pH, ketone bodies, and the chloride levels. How do you manage the case? So again, mainly treat the underlying cause that has to be corrected. A trial of IV chloride rich fluid is given if there is a high index of suspicion of chloride responsive metabolic alkalosis caused by loss of GI fluid. Okay, so this completes the case of metabolic alkalosis. In this particular case, it is the loss of hydrogen ions due to persistent vomiting leading to metabolic alkalosis. The types are chloride responsive and the chloride resistant metabolic alkalosis. So investigations, mainly the arterial blood gas analysis along with the serum electrolytes level.